So I'm Alec. I'm one of the second years, if you don't know me yet. And today, for the social EM lecture, I want to talk about opioid withdrawal and opioid use disorder in the emergency department. So I think we're probably well aware of the scale of the opioid epidemic in this country right now. But just to provide a little bit of context and highlight its magnitude, last year from April 2020 to April 2021, there were 75,673 deaths from overdose of opioids in that 1 year period. Last year, there were about 36,000 deaths from car crashes. So right now in the US, overdose deaths exceeds mortality from HIV, from guns, from motor vehicle collisions. It's one of the leading causes of deaths of Americans under 50. And every day in this country, 91 people die from opioid overdose. I think we're all aware that addiction is not a personal choice. Not that this really matters to us in the emergency room, where we take care of patients every day who come in because of the consequences of probably bad personal choices. But I think this is an important thing for us to keep in mind. I don't want to go too in-depth into the brain science of addiction, but I do want to highlight the very clear role that trauma plays in the development of addiction. So this is just one of countless studies that highlights the really strong link between trauma, and specifically early childhood trauma, and the development of addiction. So in this study, looking at people with various types of addiction, over 96% of these patients had experienced significant trauma in their lifetimes. So I just want that to keep us in mind if we're having trouble being empathetic towards these patients, that these are patients that have experienced really traumatic lifetime events and deserve our compassion and care when they come into the emergency department. So this brings me to kind of the bulk of what we're talking about today. So opioid withdrawal is a spectrum of symptoms that develops over time. And the timing of onset, of course, is going to depend on what type of opiate that patient's using as an outpatient. Historically, you would say it took, a matter of hours for IV heroin, and then maybe up to a day or so for long-acting opioid pills or for methadone. I do want to just point out that today, if we're thinking about patients using IV street drugs, we don't know exactly what's in that drug, and neither do they. So that timing is going to be a little bit different. The symptoms that patients are going to be experiencing during the early parts of those withdrawals are the symptoms listed here. So muscle aches, anxiety. This is when you're going to see that patient yawning. They're going to have runny nose. And those are going to develop over time into more uncomfortable symptoms. Things like cramps, nausea, vomiting, diarrhea, fever, chills, dilated pupils. As far as classifying these symptoms, there's an important scale that we should be aware of, and that's the clinical opiate withdrawal scale, or the COW scale. Very similar to CWA, this is a scale that's very easily accessible on MD Calc, and basically just goes through the patient's symptoms and will ultimately classify them somewhere between not withdrawing and in severe withdrawal. And this is something that we should be comfortable with as we're thinking about how do we treat these patients. Now, one important note when thinking about opioid withdrawal is that nowhere on those symptoms do we see anything that's strictly life-threatening. And that's because with opioid withdrawal, unlike alcohol withdrawal or benzodiazepine withdrawal, patients aren't going to die from this directly. However, that does not mean that opioid withdrawal is not dangerous. So untreated opioid withdrawal commonly results in people returning to the community and engaging in very high consequence, high risk opioid use. And there's a high risk of overdose death after or while patients are withdrawing from opioids. Just a few weeks ago, I hope he doesn't mind me sharing, there was a patient that was in 2 hallway, looked really bad, got ultimately triaged to the back and was picked up by Dr. Lavadera. This was a patient that had actually come immediately after AMAing from an outside hospital where she had been admitted and started on treatment for endocarditis. She most likely AMA'd because she was in withdrawal, as she immediately went out and used IV fentanyl that seemed to be laced with something else. So when she came in with us, she was altered and looked really sick. So obviously, opioid withdrawal is something that we need to take very seriously when we're treating our patients. So what can we do for patients who are withdrawing in the emergency department? So one option, and historically the most used option, is to do supportive treatment. So we can think about how can we treat the symptoms that the patients are experiencing. We can give them Zofran or Reglan if they're having nausea and vomiting, and we can use medications like clonidine. Clonidine's been shown, and there's been studies to show that it reduces the overall withdrawal symptoms of opiates. The mechanism for this is a little bit unclear. If you're interested in kind of foam med, there's a good Tox in the Hound blog that talks a little bit more about the actual mechanism for this, but I'm not going to get too in depth today. And regardless, this is not the best medication that we have access to. So thankfully, since the 70s, we've gotten more comfortable and more familiar with other medications that can treat opioid withdrawal. One of those is methadone. So methadone, as we may know, is a full agonist at the opiate mu receptor, and then has some partial or antagonist activity at the NMDA receptor. It works really well for blocking withdrawal symptoms, essentially just by occupying those opiate binding sites, and has a very long half-life, so it stays on those opioid binding sites and can block withdrawal symptoms for a very long time. It is just another opiate medication, but it's a much lower risk one. Studies have shown that patients that are on methadone have a much lower risk of overdose, though they can still overdose on methadone. It can still cause respiratory depression and other bad side effects, but that risk is just much lower. And one of the other major benefits of methadone as far as treatment for withdrawal, treatment for opioid use, is that it reduces the complications of IV drug use. So patients are taking methadone orally, so they're not at risk of getting endocarditis, HIV, hepatitis, abscesses, and all of those other complications that we see from unsafe IV administration of drugs. Now, there are downsides of methadone. So I talked a little bit already about the side effects. So methadone does cause significant respiratory depression when given in high doses, something that we've probably all seen in patients that we've taken care of. Another major downside is the inconvenience of its dosing, specifically as an outpatient when used as a medication-assisted, quote-unquote, treatment. This largely comes probably from the fact that it was introduced in 1972. It was introduced as kind of at the same time as the war on drugs, and it was specifically introduced largely in urban Black communities with the goal explicitly of reducing crime. So because of that, it was introduced with this very strict, stringent protocol. And still today, patients who are started on methadone have to come to the clinic 6 to 7 days a week, depending on if it's open on Sunday, to get their dose of medication. Now, over time, as patients show up, as they pass drug tests, they're able to get take-home doses of methadone. But this is really clinic dependent about how often these are actually given. And there were a lot of stories and reports, even during the COVID pandemic that we're having now, that patients are having to go to the clinic every single day, wait in line for their methadone. So obviously, this has a lot of inconveniences. Perhaps not surprisingly for us, you'll see when you compare methadone with buprenorphine, the other drug I'm about to talk about, there's a lot of racial segregation and geographic segregation about what types of drugs are available. And so in Black and brown communities, that's largely going to be methadone, whereas in white communities, buprenorphine is much more available. Interestingly, this actually led groups like the Black Panthers and the Young Lords, the Puerto Rican group in East Harlem and in the Bronx, to actually in many ways disavow methadone because they saw it as a substance that was really focused on controlling people. I just bring that up to kind of highlight the very tricky context in which these kinds of drugs were developed, and some of the kind of perceptions that may exist among the community about methadone or about buprenorphine. So it's important for us to keep in mind. So let's go forward to buprenorphine, which is going to be the focus of the rest of this talk. So buprenorphine, commonly known as Bupe, is a partial agonist at the mu opioid receptor. This gives us several benefits that we'll get to in a second. Generally, in the US, it's dosed as Suboxone, which is a combination of buprenorphine and naloxone. Buprenorphine is going to be absorbed orally, whereas naloxone is not. So the naloxone really doesn't do anything when this drug is taken appropriately. And the main goal of naloxone is just to stop people from diverting this to an IV drug. because injected naloxone is going to cause quite unpleasant sensations. So this stops people from doing that. So what are the reasons that we should think about using this drug in the emergency department? If you want a really succinct and good overview of this, I want to highlight Trevor's blog post from last year, largely because it makes me feel a little bit less bad about stealing some of it for this talk. So do check out his blog post. So how about for our toxicologists, for our people who are interested in tox, who are interested in pharmacology, why might they want to use buprenorphine? So as I talked about already, because it's a partial agonist, buprenorphine really is a safe, all-in-one pharmacologic solution to opioid withdrawal. So we discussed it's a partial agonist with a very strong affinity for the opioid receptor. So what this means is that as a partial agonist, buprenorphine has a ceiling effect. So you're going to give increasing doses of buprenorphine, but at a certain point, the amount of euphoria that's caused by buprenorphine, and probably more importantly, the amount of respiratory depression stops increasing. So this makes it a pretty safe drug to use. It has a stronger affinity for the mu receptor than other opioids. So this means that it can actually have a blocking effect when administered along with those other opioids. So if somebody's on buprenorphine, their opioid receptors are already saturated with buprenorphine, they're not going to experience the euphoric or dangerous effects if they were to take another drug like heroin. It has an incredibly long half-life, so you're able to dose it just once a day and prevent withdrawal for a whole day. And unlike methadone, there's no QTC prolongation, which just adds one more thing to make this a safe drug. So if you're not interested in toxicology, but perhaps you're a little bit risk averse, this is a good drug for you as well. Just to highlight the safety of this drug, I want to just point out this study that came out of Tehran last year. What this study does is really highlights the blocking effect of buprenorphine. So in Tehran, what they were doing for this study was using buprenorphine as a reversal drug for a methadone overdose. So what they did in this study, it's a small study, it's a proof of concept study. This is in no way like ready to be taken into our emergency department, but they randomized patients who came in with methadone overdose. So those were patients that had hypoxia, so O2 sats less than 90%, or a respiratory rate less than 12. And they randomized them to get naloxone as the reversal agent or to get IV buprenorphine as the reversal agent. What they actually found was a complete response, so meaning the patient no longer had respiratory depression, was awake, was talking, was more common with the patients that got the buprenorphine as the reversal agent. They also saw that the risks such as ARDS, that pulmonary edema that we see sometimes with naloxone, were much lower in the buprenorphine group. And the patients had lower risks of intubation and lower risks of recurrence of respiratory depression. So point being, not necessarily that we should start using buprenorphine instead of naloxone when we have a patient who comes in ODing on heroin, but just that this is an important drug for us to get familiar with because it may be used in other settings in the future. And at the very least, this highlights that blocking effect that buprenorphine has and why it's useful for patients to be taking buprenorphine to prevent overdose overall. So perhaps you have an interest in public health. So if you do, buprenorphine could play a very beneficial role in reducing the opioid epidemic in the US. So in France in 1995, the French government made it so that any provider could prescribe buprenorphine to a patient. So they didn't need an X waiver or any kind of special treatment or special class to be able to do this. And what they saw is that from 1995 to 1999, within those 4 years after introducing this, they had nearly 10 times as many patients that were on medication-assisted treatment than were prior when only methadone was available. Most importantly, they saw that the overdose deaths in France were reduced by 79% in those 4 years. So how about for our administrators or the people that are interested in emergency administration? So first, kind of lowest hanging fruit, buprenorphine can be used relatively quickly in the emergency department. So one study looked at an average length of stay for patients that were being started on buprenorphine of about 2.4 hours. Something tells me it might be slightly longer than that at county, but the point being, this isn't necessarily something that needs to take a long time to use. Patients aren't going to be sitting there all day, or at least not just because they're getting buprenorphine. More importantly, though, in this kind of flagship study coming out of Yale, they saw that patients that were started on Bupe in the emergency department were much less likely to require inpatient services. And of course, that makes sense. Furthermore, we can see that patients that are started on Bupe that are connected to buprenorphine are much less likely to use the emergency department in the next year. So this is a study that came out of SUNY Upstate. They looked at patients with opioid use disorder, and they compared basically the 6 months prior to, and then the 6 months after starting their bridge clinic, their buprenorphine clinic. And what they saw is that for patients that were connected to the buprenorphine clinic, ED visits decreased by 42% in those 6 months after they were connected to that clinic. So this could definitely have a pretty beneficial impact on crowded EDs. Now, there are a lot of high quality evidence and high quality studies that support the use of buprenorphine. So there's multiple large systemic Cochrane reviews that look at buprenorphine, comparing it to placebos, comparing it to clonidine and those other medications. So with this one, and comparing buprenorphine to clonidine, they showed that buprenorphine was more effective in managing withdrawal in terms of severity of withdrawal and duration of withdrawal. And it was more likely that the patient would complete treatment with buprenorphine as opposed to with clonidine or those other medications. Of note, most of the evidence comparing buprenorphine to other things like methadone show that buprenorphine and methadone are both effective. We've talked a little bit about some of those other reasons maybe we would want to use buprenorphine over methadone, but the evidence really supports both of them as safe, effective medications in treating withdrawal and treating opioid use disorder. Looking at the study or the systemic review of comparing buprenorphine to placebo, what we find is that you need to treat 2 patients with buprenorphine in order to keep 1 patient in treatment of their opioid use disorder. So this is a really effective medication and one that we should get comfortable using in the emergency department. Now, if none of these apply to you, you're not interested in public health, admin, or really evidence, and all you want to do is to show up to work, do a good job, help people, and save lives, buprenorphine is a medication that you should be familiar with. In this study from just a couple years ago, they looked at patients within 1 year of a non-fatal overdose, and they saw that treatment with methadone or buprenorphine cut mortality for those patients in half. So 1 year after overdose, patients had about a 5% chance of dying, and you can cut that in half if you can get them connected to buprenorphine or methadone. So hopefully now we can see some reasons why we ought to think about using buprenorphine in the emergency department. So let's talk about how we're going to use it. So there's various algorithms for ED induction of buprenorphine. Most of them look pretty similar. The first step is always going to be make sure the patient wants to take buprenorphine or be started on buprenorphine, and then to make sure that they are in withdrawal. This is probably the most important step, and we'll get to that in a second here.
The PS2 is one of my favorite games.
And the reason that this, in thinking about withdrawal, what we need to do is make sure that the patient has a CAL score. So going back to that MD calc score that I talked about of greater than 8 to 10. So that's going to be the first step. If they're not there yet, you can wait, or you can potentially have them do this at home, which we'll talk about in a second. After that, you're going to administer the first dose of buprenorphine. The dose of this is going to vary depending on who you talk to. It's going to be somewhere between 2 and 8 milligrams. Most of the online algorithms say somewhere between 4 and 8 milligrams, 8 being for people that are heavier opioid users, 4 being for people that are slightly lighter opioid users. But in talking to Dr. Jennifer Mark, who's one of our addiction specialists at Kings County, she actually likes to start with 2 milligrams as sort of a test dose to make sure that the patient's doing okay with it. And then quickly from there, going up to those higher doses of 4 to 8. After you do that, you're going to give 30 minutes, an hour, and you're going to reassess that patient. If they're still withdrawing, you're going to give another 4 milligrams. With the goal of getting up to about no more than 16 milligrams. There are some people, I think like Ruben Strayer at Maimonides talks about how really you should try and get everyone up to 16 milligrams. So if they're not 100%, you should give them another dose. The reason for that is the higher dose you get them on that first day, the longer time theoretically they have to make it to their outpatient appointment before they start withdrawing again. So you could benefit from giving them another dose if they're not quite at 100% yet. Now, what if they're doing worse? So this is where we will need to talk about probably one thing you've heard about with buprenorphine, which is precipitated withdrawal. Precipitated withdrawal is probably the major side effect that we need to think about when using buprenorphine in the emergency department. What happens with precipitated withdrawal is if that patient wasn't in withdrawal already, the buprenorphine is going to knock off those other opioids that are in their system, and it's going to throw them rapidly into withdrawal, similar to what we see with naloxone. Now, theoretically, you could get autonomic instability, ARDS, pulmonary edema, like you do with naloxone, but that's probably not going to happen at the doses we're giving it here and for the patients that we're inducing on Bupe in the emergency department. Really, the major concern about precipitated withdrawal is that you're going to potentially turn people off of Bupe. And you're going to make it so that someone doesn't want to in the future start this potentially life-saving and life-altering medication. The best way to manage this is by avoiding it in the first place. So you really want to make sure that patient is withdrawing before you start giving them this medication in the emergency department. That being said, this still might happen. In most of the newer literature is saying that the best treatment is just to give them another dose of buprenorphine. So if you see this, give them more buprenorphine. That being said, if you're getting up to those doses that you're uncomfortable with, higher than 16 milligrams, or the patient is refusing to get anything else, you could give them those other medications that we talked about earlier, like clonidine, like Zofran, or you could even consider giving them methadone if that was something that they were using as an outpatient before. So after all this, of course, like with anything else, you dispo the patient. They're being admitted, place a catch addiction services consult, or you figure out how to get them started on buprenorphine as an outpatient. Really quickly, there's a couple special populations that we might want to highlight in thinking about this. So theoretically, patients with very significant liver disease, so significant cirrhosis or hepatitis, you might want to think about adjusting your dose or giving a different medication. Literature says somewhere like if LFTs are greater than 5 times normal, you might need to think about adjusting the dose. That being said, you don't have to check LFTs before you do this. So unless you have some reason to strongly suspect that the patient's going to have significant liver damage, you don't need to check labs or check LFTs before giving this medication. For pregnant patients, historically, there is some talk about just giving buprenorphine rather than the buprenorphine naloxone mixture to pregnant patients. But Suboxone is an okay drug to give in pregnancy as well. You do need to note that patients, if they're put on buprenorphine during their pregnancy, the child will have neonatal abstinence syndrome. But the literature suggests that this is much, much safer than having the mother who's actively using opiates and street drugs throughout the pregnancy. So you can give this to patients who are pregnant. You don't necessarily have to check a pregnancy test before starting this. But if they are pregnant, you probably want to do this in conjunction with the addiction services team and potentially with their GYN. And the last group to think about are patients that are intoxicated or on some other substance, or just have some other reason to have pre-existing respiratory depression. We talked about there's a ceiling effect of the respiratory depression that buprenorphine is going to cause, but if those patients are already respiratory depressed for some other reason, that could be significant. So it's something that you want to think about. Now, as I mentioned, this same process could be done at home by the patient. So if the patient comes in and they're not in withdrawal, but they want to start buprenorphine, this has been done for many, many years at home by patients and is safe for patients to do. And they're going to do more or less the same thing that you do as the emergency provider. That being said, to do this, you do have to prescribe the patient buprenorphine outpatient. And for that, you do need the X waiver. The X waiver may be something that we've heard of. The X waiver is an 8-hour course. If you look at PCSS, you can do it for free online, and it may be worth doing. It's a lot of good educational material. But the main reason I want to bring this up here is that you do not need an X waiver to use buprenorphine in the emergency department. So this should not stop you from starting the patient on buprenorphine when they're in the ED. In fact, even without an X waiver, you can have a patient, the same patient, come back to the ED for 3 days in a row to get buprenorphine. So you can essentially start them on buprenorphine in the emergency department, have them come back until they're able to get connected as an outpatient. So that brings us to this. The greatest benefit of starting buprenorphine in the ED is going to be continuing that treatment as an outpatient. And this can be accomplished in several ways at Kings County. So first, if your attending is ex-waivered, you could just send them a prescription for buprenorphine and they can start this at home. If it's Friday night, you could have that patient come back to the ED on Saturday and Sunday and get their second and third dose before they're able to go to the clinic on Monday. And for us, we are fortunate to have a very capable bridge clinic, essentially, in the substance use disorder clinic at the R building. This is open Monday through Friday, 8 a.m. to 4 p.m., and there's no appointment needed. So the patient can just walk from the ED over to the R building and have an intake appointment. That being said, you should still place a catch services, so an addiction consult. And if you want to, you can always call over to the R building to tell them about this patient that's going to be coming over, but none of that's necessary. The patient can just walk in. At Downstate, we have the STAR clinic. The number's here for an appointment. So you can try to call them and set them up. I don't know exactly how long that's going to take. Of course, if there's an issue, there's nothing stopping them from walking across the street to the R building. So what if they're not interested in being treated as an outpatient? So as I mentioned, the main goal to starting buprenorphine in the ED is to bridge them to that outpatient therapy. But there are some good arguments that patients can still get buprenorphine, even if they don't want to keep taking it as an outpatient. So say you have that patient with endocarditis who's going to be admitted, you could consider starting them on buprenorphine during that admission. The benefits of this could be that one, it's a good medication to treat their withdrawal. And two, you might show the patient that there's a medication that can help them when they're ready to get that help in the future. So before we finish, I just want to highlight a couple future directions or kind of things that we should look out for in the future when it comes to buprenorphine. The first is, as I mentioned, we typically stop at about 16 milligrams on day one, even if that patient's still in mild withdrawal. But there's some literature and some newer evidence coming out of Highland, out of Yale, that you can actually get up to much higher doses and still prescribe this medication safely in the emergency department. So in this study, they were giving patients up to 32 milligrams of buprenorphine on the very first day. And they were seeing that this was safe, it was reducing their withdrawal, and it was giving patients a little bit more time to make it to those outpatient appointments. So just keep this in mind as we start using buprenorphine. On the other end of the spectrum is giving patients really, really, really small doses of buprenorphine when we're starting. So what might be the reason for that? The main goal of doing that is to figure out a way to get patients started on buprenorphine without them ever having to go through that very uncomfortable withdrawal period. This can be done in several ways. There's people who are using buprenorphine patches, but the most common way that this is done is what's called the Bernese method. Essentially, what happens here is patients are started on really small doses of buprenorphine, so somewhere between 0.2 milligrams and 0.5 milligrams, and they're given those small doses that aren't going to cause them to withdraw while they're still using either their street drugs or their methadone. And then slowly over the course of 6 to 10 days, they're given slightly larger doses of buprenorphine, and ultimately the drug they're using in addition is tapered and stopped. And they're able to transition seamlessly without having any of that withdrawal. This is something that we're starting to do at Kings County. The addiction services team is working on a protocol to do this. And where this could be potentially really useful for us is in switching people who don't want to be on methadone anymore to buprenorphine. With methadone, you usually have to wait like 72 hours for them to be in significant enough withdrawal to induce them on buprenorphine in the traditional method. And often patients don't want to wait that long with mild withdrawal symptoms. And so this would be a way to potentially switch them over without them having to go through that really long withdrawal period. In the emergency department, we could think about both these methods being potentially useful for us when we have patients that come in after naloxone reversal. So this is something that is relatively new, is probably not ready for prime time yet, but it's something to think about when you have patients that are coming in after being reversed with naloxone. So there's some evidence out of, I think, Highland, and then there's this paper out of New Jersey where they're actually allowing EMS to do this, where they're having patients who overdose, they're giving them naloxone, which then pushes them into withdrawal, obviously not intentionally, but pushes that patient into withdrawal. And then they're immediately giving that patient a high dose of buprenorphine, like 16 milligrams or 32 milligrams, and they're able to treat those withdrawal symptoms. In New Jersey, they're allowing EMS to do this. And the reason they think that's beneficial is there's actually a lot of patients that overdose, get reversed in the field, and then refuse to come into the emergency department. And so this study is interesting. It's like 3 patients where they gave that patient had withdrawal. They gave them buprenorphine rather than going out and using whatever street drug they were using and potentially overdosing again. And then those patients just followed up the next day at their bridge clinic. We can think about microinduction being useful for naloxone reversals in the ED. If we're giving them more elegant reversals where they're not being pushed into significant withdrawal, you could theoretically start that patient on 0.2, 0.5 milligrams of buprenorphine in conjunction with the addiction services team, and then have them follow up to continue that microinduction as an outpatient. And you could do this without pushing them into significant withdrawal. So hopefully we now have many reasons to think about wanting to use buprenorphine, but there still might be some qualms. Not infrequently, people think, why would we want to spend so much effort doing this when all we're doing is replacing one addictive substance with another? And we really need to think about that's not exactly what we're doing. What we're doing is we're replacing a life-altering, life-threatening drug with a much safer one. Obviously, what we're doing is not curing their opioid use disorder, not curing their addiction. We need to remember that a lot of what we do in emergency, frankly, most of what we do in emergency is not providing cures. Often, just like with this, what we're doing in emergency medicine is treating whatever symptoms brought them into the emergency department, in this case, opioid withdrawal, and hopefully setting them up with a disposition that gives them the best chance at leading a successful, healthy life in the future. And frankly, I think when it comes to opioid use disorder, this is something that we can do a lot better at Kings County and downstate. So with that, I'd just like to thank Dr. Kindle, Dr. Warshaw, Sim, Lavadera, Dr. Pula, and Dr. Mark. And I'd love to take any questions at this time. So thank you.